Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at ETSU's Bill Gatton College of Pharmacy. And this podcast is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. I've got a couple, maybe four things to discuss today. The first I want to talk about was a notable retraction in a Nature journal for what was described as a randomized controlled trial of timing of immune checkpoint inhibitor immunotherapy in patients, and this was in China. That has been retracted because it turns out it was looking like it was really a retrospective study that they said was a randomized prospective study, and it was caught based on some somewhat obvious errors that, to be honest, I missed when I didn't review the study as in-depth. We talked about this on a prior podcast. When the study came out, there is, quite a bit of observational data that maybe the timing of when you give immunotherapy early in the morning, that it might work better. This was a prospective study that added the most evidence to that, but it turns out it didn't add a whole lot. So just wanted to note that had been retracted. And then we have a couple FDA approvals to talk about. The first one I'm going to talk about is PATINA, and this is an approval for based on a study that we talked about in January. PATINA is a pabociclib study. It was published in NEJM in January of 2026. And these patients on this study, there were about 500 patients, and they're getting, they call it induction chemo, I think, but it's like first-line chemotherapy. So this would be like a taxane, trastuzumab, and pertuzumab. Not everyone got pertuzumab because that isn't the standard all around the world. So up to 20% of people just got taxane, like docetaxel and trastuzumab. And, after your 6 cycles of that, then they went on to a maintenance of HER2 blockade with hormonal therapy plus or minus pabociclib. That's PATINA, which we talked about. And so, with this, we do see, a modest improvement in progression-free survival. That hazard ratio for PFS is 0.76. It's all right. 95% CI is 0.59 to 0.97. OS is immature at this time. This is in the guidelines. It's a plus or minus for these folks. So it's kind of like all the guidelines with bevacizumab. Plus or minus bevacizumab. You don't have to. So this is basically maintenance palbociclib for these folks. What is unique about this is the approval. I'm kind of bearing the lead here. First time for HER2 positive disease that palbociclib has an approval. And we talked about this on the earlier podcast, that the CDK4/6 inhibition can overcome some of the resistance, not just to hormonal blockade, but also to HER2 blockade. So this is kind of proof of concept here with our PFS benefit. One of the things that is going to worth monitoring, I think, in practice is people will add this. It adds a very well-known and consistent toxicity profile that we're pretty familiar with palbociclib from years of use, almost a decade probably at this point in the metastatic setting. What is a little bit unclear is we have the data for FAM, trastuzumab deruxtecan plus pertuzumab in the first-line setting for metastatic breast cancer, which shows improved PFS. We don't have the overall survival data yet on that, just like we don't for palbociclib. A lot of the guidelines and clinicians are still preferring the traditional, kind of THP approach for this. But I would not be surprised if FAM, trastuzumab deruxtecan takes over as the preferred. And, TDXD, or FAM, trastuzumab deruxtecan, has about 11% risk of interstitial lung disease. There is a risk of that with palbociclib, about 2.5%. Probably very few people have received palbociclib sequentially with TDXD, and so there's a question of, is there going to be an increased risk? Is there going to be a safety signal of interstitial lung disease if you were to use those sequentially? And that's something that we don't know at this point. So that is out there. So some of you, if you're educators, you probably have slides somewhere that say palbociclib can't be used for HER2 amplified disease. Well, it can. We have some data now, okay? And we have the FDA approval. Well, a lot of people who listen to this podcast, they're just trying to learn oncology. Maybe they're new to the specialty or just trying to deepen the understanding of a particular disease state. To help, Kelly Carlstrom, founder of Kelly C. PharmD and the ELO Collaborative, created the Learning Oncology Companion. It's a free template that provides a structured framework for learning any cancer type, help you organize key concepts like risk factors, symptoms, biomarkers that need to be tested or dictate treatment, staging, as well as treatment strategies. Download the Learning Oncology Companion using the link in the show notes for free. Okay, the next approval to discuss is sacituzumab, govitecan plus pembrolizumab for triple-negative breast cancer. Ironically, this was published in January of NEJM at the same time in 2026, I'm pretty sure. I don't think I talked about this on the pod. That does illustrate some of my bias against sacituzumab govitecan, a drug that I have not thought is all that wonderful. And maybe I'm going to revise to say I don't think it's all that wonderful as monotherapy. So this drug gets 2 approvals. One of them is less exciting to me than the other. So the first approval is ASCENT-03. And this was sacituzumab govitecan, single agent for triple-negative breast cancer patients who are not a candidate for PD-1 or PD-L1 therapy. And I think this is a small patient population, but I think it is wise for someone to study this patient population because these people are excluded from all these clinical trials. So these are people with rheumatoid arthritis that's very poorly controlled, for example. And so it's better than, a physician's choice chemo, which is either nab-paclitaxel, Abraxane, regular conventional paclitaxel or Taxol, and then gemcitabine and low-dose carboplatin, so AUC2 carbo on days 1 and 8. So carbo and gem on days 1 and 8 of 21-day cycle. And so we do see a, improved median progression-free survival there, better response rate, OS data immature. But, okay, that's great. But a small patient population, folks who aren't candidates for PD-1 or PD-L1 inhibitors. What is more interesting is the second approval, which is an approval in the first-line setting for triple-negative breast cancer. And this is sacituzumab govitecan in combination with pembro. So it's sacituzumab govitecan on days 1 and 8, and then pembro or the sub-Q pembro bear hyaluronidase every 21 days. And this is based on ASCENT-4/Keynote D19. So you've got the pembro folks have one name, the SG folks have their other name, right? And so we have to have 2 names for this study, which is great. I just love it. So ASCENT-04 is randomized phase 3 controlled study, about 400 patients. Triple-negative breast cancer is not as common, obviously, as hormone-positive, HER2 unamplified disease. So a smallish study, 440-some patients randomized to either sacituzumab govitecan and pembro or chemo plus pembro. And the chemo is the same backbone that we just talked about. So it's nab-paclitaxel, or carbogem. And this is the same chemo backbone that was beaten by chemo plus pembro in Keynote 355, which was a much larger study of all patients with triple-negative breast cancer. What they found in that study is there was improved overall survival with the addition of pembro in those folks who had a PD-L1 composite proportion score, so tumor and immune cells, greater than or equal to 10%. So this is an enriched patient population where we see the benefit in the metastatic setting for PD-1 inhibitors like pembrolizumab. Now, in the neoadjuvant setting, we don't have to worry about PD-L1, but in the metastatic setting, we do test for PD-L1 because that is what Keynote 35, that's what the data illustrated, that's where the benefit was. So this is that same chemo and pembro standard of care. And then we have sacituzumab govitecan versus pembro. So it is a good comparison. And we see an improvement in progression-free survival here. The overall survival data are immature. They're about 25% maturity if you just kind of eyeball it here. And we don't see any improvement in overall survival. If you look at these patients in the study, pretty similar to what we saw in Keynote 355. About half of them got taxane, half got carbogem. That's very similar to Keynote 355. We don't know from ASCENT-04 what breakdown of folks got paclitaxel, conventional versus nanoparticle albumin-bound paclitaxel, which is potentially of interest. In Keynote 355, a third, 35%, got nab-paclitaxel, who would not necessarily have to get get corticosteroids as pre-med for hypersensitivity reactions, which they would before conventional paclitaxel. And in theory, could decrease the effectiveness of the pembrolizumab in this arm. Now, that's the same between both arms, so, everyone's getting pembro in the study. So that risk is probably a little bit mitigated here. So we do see a pretty sizable improvement in median progression-free survival, certainly more of an effect size than we see in PATINA with palbociclib and the HER2 positive folks. That hazard ratio is 0.65, 95% CI is 0.51 to 0.84. When you look at a 12-month estimate of progression-free survival, 48% versus 33%, so pretty large effect size there. The OS data immature, about 25% maturity, like 50 and 60 people have died in each arm, and you got about a little over 200 on each arm. That hazard ratio is 0.89, 0.62 to 1.29. So there's, if you just look at the tail of the curve, it looks like maybe there is a trend of improvement with SG over chemo plus pembro, SG plus pembro, compared to chemo plus pembro, but we can't really say that at this point. So, our favorite guidelines have included this sacituzumab govitecan plus pembro as on equal footing as chemo plus pembro. And so, when you look at the data, they at least for the overall survival, I don't think you can make a case of one over the other. And so what people are probably going to do in practice now that this is approved and should be widely available and from payers is look at the side effect profile. So if we look at our side effect profile, we see a whole lot more diarrhea with sacituzumab govitecan. This is a TROP2 targeting monoclonal antibody conjugated to SN38, which is the active metabolite of irinotecan. When SN38 gets glucuronidated, it gets excreted in the bile and causes all kinds of damage in the GI tract, and that's where we get the diarrhea, okay? So 70% diarrhea with SG pembro compared to 29% with chemo plus pembro. 10%, 1 in 10 had grade 3 diarrhea, which I think is more than 8 bowel movements a day, or you have to be hospitalized, okay? So 1 in 10 severe diarrhea, pretty common. There was more nausea with SG plus pembro compared to chemo plus pembro. Now, half these folks getting chemo are getting, low-dose carboplatin plus gemcitabine, not very emetogenic, or single-agent taxane, also not going to be highly emetogenic. So 68 versus 38, a lot more nausea with sacituzumab govitecan. And worth noting because, if you're kind of a superficial or maybe not that experienced in oncology, you hear we're given sacituzumab. People may not finish the govitecan, and you don't think that has a cytotoxic payload that has quite a bit of nausea. The neutropenia rates were similar between these arms. Fatigue was similar. More alopecia with sacituzumab govitecan versus chemo. Again, both arms are getting pembro. 52% alopecia with SG plus pembro versus 32% with chemo plus pembro. Very important for the breast cancer population. That alopecia is a big concern. Much less likely to happen if the chemo pembro arm here. Anemia was less common with SG pembro, 37 versus 51%. More vomiting in line with the nausea we saw with SG plus pembro. There was less neuropathy and less thrombocytopenia. And that's notable because a lot of patients will have underlying peripheral neuropathy from long-standing diabetes, for example. SG plus pembro makes more sense in that patient population. Folks that have, maybe questionable platelets at baseline, or they're on anticoagulation, especially with some baseline thrombocytopenia, SG plus pembro looks safer than chemo plus pembro. Now, that 29% of thrombocytopenia that's higher with chemo plus pembro, that's probably carbo and gem. Both those drugs, the DLT, is thrombocytopenia. Less likely that's going to happen with taxane. So you probably still could do taxane, pembro, and have the same thrombocytopenia risk versus SG govitecan plus pembro. And then, that is an option. I just looked in our, we don't have this order set built, SG govitecan plus pembro, but that's something that we will have to get on. And then I just am, for brevity, I didn't go through all the methods, but I do want to point out that, as in many new studies with immune checkpoint inhibitors, the duration of pembrolizumab is limited to 2 years. Which brings me to the last little ditty, which is a clinical implications of basic research publication in NEJM from last week. These are really, really good. They're short. They're usually 2 to 3 pages, and they're highlighting some basic science research that may be the next thing. These are really good, and this is called Stemness as the engine of checkpoint durability. And there are 2 things here that are called out that I had not heard of before. One is interleukin-7. I've heard of interleukins. Haven't heard of interleukin-7. It's not a drug target. I've heard of IL-6 because you target that with tocilizumab. But I haven't heard of interleukin-7, which is a cytokine that is needed for T-cell survival, proliferation, but especially for certain types of T-cells, like stem-like progenitor T-cells. And these are T-cells that maybe you could almost think of this as a pluripotent T-cell that can differentiate further to recognize different antigens. And so what some of the research has suggested here that they highlight is that we know with long-term PD-1 blockade, like with pembrolizumab, that you can end up with some T-cell exhaustion, and that could then lead to tumor recurrence. And so what they describe some nice basic science experiments here where they actually found out that PD-1 signaling is helpful from an immune standpoint, and that PD-1 binding to PD-L1, we think of it as a brake pad, but PD-1 we think of it as a brake pad for the immune system. But PD-1 binding to PD-L1, it does block effector T-cell activity, but it also promotes the development of these stem-like progenitor T-cells, which do have some anti-tumor effects in the tumor microenvironment because they're able to adapt to new neoantigens that maybe occur as the cancer is regressing and dying and undergoing mutations as things change. And so what this kind of suggests, the analogy that I'm working on here, if we think of PD-1 blockade as cutting the brakes, you can almost think more of PD-1 as a clutch. It is used to change gears. So it does block the effector T-cell activity, or the inhibition of the T-cell activity there. So it allows the T-cells to go kill cells expressing neoantigens like tumor cells. But it also can kick the immune system into a different gear with the development of these stem-like progenitor T-cells. And this seems to be driven by interleukin-7. And so there are some exciting experiments done where adding IL-7 to an immune checkpoint inhibitor increases the tumor killing, the duration of the tumor killing, and helps mitigate T-cell exhaustion where the T-cells are just tuckered out or they aren't there anymore to be able to kill the tumor. That adding IL-7 can help with the added anti-tumor effect with immune checkpoint inhibitors, but doesn't necessarily lead to more autoimmune toxicity. So this is a really exciting, and the more you learn about the immune system, the more you realize, boy, we don't know nearly enough about how this works and how to use it to fight diseases. So more and more proof that 10, 20 years from now, we're already using tons and tons of immune checkpoint inhibitors. When I teach in the spring, I'm probably going to reorient how I teach to lead with teaching about immune checkpoint inhibitors, partially because they're not discussed as heavily in the pharmacology as antimetabolites and alkaline agents, for example, but also they're just like becoming more important. Certainly by volume of use and volume of sales, they're way more important to a practice, and they're increasingly important in the curative setting as well. So that is, I'll have a link to this for those of you that want to read it by yourself. But a really interesting study, really insightful, really enjoy reading about the basic science of this, which is the backbone for a lot of what we do in oncology. So thank you so much for listening. You can follow me on X at PharmDeetNib and the show at various social media outlets at UnclePharmPod. And until I talk to you again, remember, doses matter. Thank you.